Trisha has earned both her BSN and MSN from Bethel University and began her nursing career with Parkview in 2014. Over the past 11 years, she served on 5 surgical at PRMC in a variety of roles. Please welcome Sydney and Trisha.
Hi, hello everybody. That's how I start every greeting. Everybody makes fun of me because I always double hi, hello. I know it's after lunch and after dessert time, which we're all surprised. You're one of two people. You're digesting your food or you're nodding off at this point. Both are completely understandable. Lucky for you, our topic is turn team, so we can talk a little bit about movement. Alright, so on 5 surgical, that's where I started my nursing career. I just happened to notice that we had a decrease in our turn compliance, which also increased our HABIs. So we were consistently between 60 to 70% in our turn compliance. There was a lot of confusion between nurses and techs, who was doing what. I know I'm guilty. I'm thinking my techs are doing my turns at 8 a.m., but in reality, they're also doing report, so they weren't doing them either. Each patient we typically saw had a different turn time. Oh, I turned 7 at 7:30, but then I turned 10 at 7:45, and it just keeps going on from there. Everybody's at a different hour, no one was consistent. So it really just was never the same for any patient.
So after we realized this, we discussed our findings with our NCAT team. Our NCAT chair, Sydney, and another PCT on the unit, also named Sydney, brought forward the idea of implementing turn teams to the unit. So pre-implementation, which was Q1 of this year, we had mandatory unit meetings to discuss the turn team idea process, and we also received education on properly completing our grading scores. Thank you, Jeanette. We also ensured that prior to implementing turn teams, all staff were keeping our grading scores as consistent as possible. Prior to implementation, we had about a 2 or 3 point difference in grading score from shift to shift.
So we decided turn gradings were a good idea because, like that lack of communication between the nurses and techs. We all get busy, we get stuck in rooms, techs will get stuck in rooms, bathing the patients, all that good stuff. And then nurses, we get in with a patient who we think is going to take, 20, 30 minutes max, but then we're stuck in there for an hour, and then, that hour goes by and we're already behind. We were missing some turns also right at shift change time. Night shift would leave it for day shift would think night shift's covering it, or oncoming nurse versus outgoing nurse. It's just that shift change time is very hard. So it's kind of where we highlighted we really needed to work as a team to get this team-based approach to actually making sure our patients weren't being neglected and giving them the opportunity to have better quality outcomes.
We found that trying to improve turn compliance without teamwork is kind of like trying to move a hospital bed by yourself. It's technically possible, but you regret it immediately.
So turn teams work. We have tried a couple different things, but I'll go into that in a little bit. So it's a team-based approach every 2 hours. So we do them on the even hours, 8, 10, 12, 2, 4, 6, and that follows at the nighttime hours as well. Don't try to quiz me on military time because I will fail. So the assignments are all made by the previous shift lead. So the night shift nurse lead would make the assignment for day shift, and day shift would make it for night shift. Trades were always allowed. I know sometimes during the day, one of my patients was going somewhere at this time and I wasn't available to go do my turn. I would ask another fellow coworker on my floor, like, hey, can you cover this time for me and I'll cover yours. So we allowed trades pretty easily. We emphasize on patients with rating scores 18 or less, and we also wanted to prioritize our 6 and 8 o'clock hours, both AM and PM, because our our shift change on 5 surgical was 7A to 7P and 7P to 7A. So our shift change times were right in the middle of those 6 and 8. So we made it so techs and students were primarily responsible for the 6 and 8 o'clock hours, just to give a little relief to those nurses who were, getting report. If a report takes a little longer, they have to start those turns right away. It was nice for the techs and students to be able to step into those times and be primarily responsible. So some of the initial resistance that I got after, bringing it up to MCAT, having the approval from my op lead and my manager to get this going, was, this is stupid, it won't work, I don't want to participate in that. There's a lot of pushback. People really did not want to do this. So, hearing that, like, it's my baby, I started this, and it's like, okay, cool, awesome, I'm glad. But we still stuck through it. We spoke to, especially one of the main concerns people talked about was like, what do I do if I walk in and the patient is incontinent? It's like, okay, yeah, let's figure that out. It was one of our trials. So we really did, stay with the patient, one person, the other person would go get the nurse or the tech that's on that patient, and then coming back to them and cleaning them up. So, yeah. Some other feedback from staff was when we get float staff from other floors when we weren't fully staffed, them not participating, mostly because they didn't know about it. We're the only floor who was doing it, so it was kind of a lack of communication. So we worked on that quite a bit. And then confusion over time slots. We made sure people understood when their times were and so on. And then documentation and scheduling, just to help improve the participation, when to document, how you were documenting, all that stuff. So our trials and requirements, we trialed the odd hours. We trialed 7, 10, 11. Sounds even weird saying it. It was initially going to be tried for a week, and then we lasted 24 hours before we were going back to even hours. It just kind of confused everybody. And then we developed a unit list within Epic that had each patient on there whose grades were 18 and less. And then we also used the HABI predictive model to help identify patients who were more at risk versus other ones in case we had a big list of patients who returns.
Like Sydney said, we trialed odd hours initially set for a week, but we lasted 24 hours. It was apparent that the odd hours were not working for staff, so we made the decision to move back to even hours right away, just to kind of prevent disengagement with this still new process on the unit. And even with the education in first quarter, our grading scores were still fluctuating some based on the individual interpretations, although they were fluctuating a little bit less than before. But like Sydney said, we added in the HABI predictive model to that list, kind of assist with prioritization, and it just helped everybody kind of prioritize a little bit better. We also relayed to staff that they could use any form of documentation that worked best with them and just to communicate with their partner. So some people use Rover, some people chart at the bedside, and others chart after all of the turns are completed. Staff also use Unit Secure Chat, the group chat, to tell everybody when turns are completed and documented, and then also notifying of any patients who refuse their turns.
Alright, before we started turn teams, it was like trying to move a patient, felt like trying to summon coworkers out of thin air. Now that it's a coordinated effort, it lets us, let's look at the numbers and reflect how it's helped.
So we wanted to highlight the increase in turn compliance and decrease in HABI rates. Staff appreciated the shared responsibility and the improved teamwork. So the average number of patients we have on the unit per day that need turns is about 10 on a 36-bed unit. And so it takes about 20 to 30 minutes from start to finish when you start doing the turns to when you finish. And another benefit is that we now have up up to 15 staff members looking at a patient's skin per shift rather than 2 to 4 staff members, how we were doing it previously. So this graph just shows where our compliance rates were with turning before we implemented turn teams and then after. So at first our turn compliance numbers were pretty flat, which unfortunately was also true for some of our patients. So this just shows that we have consistency in the new process and the staff understand the expectations of the turn team. We are now hovering anywhere from 80 to 85% on a monthly basis for our turns. This slide just shows what our half-eye count was pre-implementation and then post-implementation. These numbers do not include any injuries caused by a medical device, but they do include injuries on the sacrum, coccyx, back, and knees. And we had also no half-eyes for October of this year. So we just want to mention that our 2 North Extended Friends have already rolled out turn teams on their unit, and then 5 South and 6 South are looking to possibly implement this in quarter 1 of 2026. And we just want to thank the entire 5 surgical team, the unit leadership, our CNS and our NPD, and our PCT peers.
Do you have any questions for Susan and Trisha? Yes, sir.
How do you guys handle turn refusals?
There are some, but with having 2 people in the room together, it's really helped kind of bounce that education off of each other for the patient, and we get really persuasive with it. So I would say we see some, but not as much as we did before.
Also, like when you go in, you're announcing, "Hey, we're here to turn you." Like we announce, like, "Hey, we're turn teams. You're getting turned."
Yeah, one unit within PRMC has already started, and I think there are at least 2 others that are looking to implement in the future.
Wouldn't it be nice if there was a turn team for the whole hospital that was just the team that did it?
Yeah, that would be awesome.
Please hire people to turn the beams.
Any other questions? Hey, thank you both so much.